So my name is Simone Nardin. I'm from Italy. I'm an intern in the University of Genoa, so in the north of Italy. And now I'm currently working with Professor Alessandra Gennari in Novara, that is a city close by Milan. Yes, the study was based on what we usually see during our clinical practice, that is related to the patient undergoing adjuvant endocrine treatment for patient premenopausal for luminal early breast cancer. So the patient that usually at moderate high risk of relapse that are administered with GnRH analog plus tamoxifen or aromatase inhibitor. Usually we saw that during our clinical practice, sometimes the patient we are visiting are not adequately suppressed related to the ovarian function, but we don't know which factor could be related to this problem and which impact on the outcome of this patient could be administering an aromatase inhibitor when the ovarian function is still ongoing. So we try to perform an exploratory analysis of two observational prospective study in order to assess if we can somehow predict which patients are more likely not to be suppressed during the administration of GnRH analog, and if this suboptimal ovarian suppression could impact the long-term outcome. So related to the baseline characteristic of the patient, only the use of aromatase inhibitor is related with a higher risk of suboptimal ovarian suppression. And in our cohort, we saw that this problem is not related only after the first year of treatment, when we have about 8% of the patient with a suboptimal ovarian suppression. But going throughout the year of treatment, so at 5 years of treatment, that usually is the standard of care, this percent goes up to 20%. So 1 out of 5 patients treated with GnRH analog plus aromatase inhibitor is not adequately suppressed for the ovarian function. This could be a problem because we saw that usually the standard for the patient is to be suppressed and have a lower level of estrogen detected by lab test. In this patient, the estradiol levels are above the limits, and this could impact the outcome. Fortunately, in our cohort, none of the patients with a suboptimal ovarian suppression has relapsed. But we have a short follow-up. We have only about 4 years of follow-up that for those patients probably is not enough to assess the long-term outcome. So we need probably a longer follow-up to see if the administration of those aromatase inhibitor in those patients that are not adequately suppressed could have an impact on the relapse or on the long-term survival of the patient.